Chapter 23, Respiratory Anatomy, Screencast 3. This screencast will be focusing on the anatomical structures of the trachea and the bronchioles. The trachea, quite often known as the windpipe, it is an open tube that's connecting the larynx to the main bronchi. The gross anatomy of the trachea, it's in front of the esophagus, behind the sternum. It's about 3.5 centimeters long and about 1 inch in diameter. The tracheal cartilages, they actually will be supporting the anterior and lateral walls, and it's important to keep in mind that these are C-shaped rings of hyaline cartilages. They're going to be ensheathed in this perichondrium, and it's a dense fibrous membrane, and the shape of this actually makes sure that the trachea is always open. The rings are actually connected to each other above and below by a ligament known as the annular ligaments. Here we can actually see, overall, the trachea, very characteristic as far as the cartilage, so lots of cartilage overall. We can actually see here a histogram, and we see the trachea here, the esophagus behind. Also see, once again, a predominant amount of cartilage in this area. And keep in mind, the cartilage, one of the things that it's going to do is really keep the airway open, a very rigid structure for the most part. Now, the histology of the tracheal wall is interesting. If we look at the innermost, once again, the mucosa, this is going to be a pseudostratified ciliated columnar epithelial tissue. There is a submucosa. We'll have this areolar connective tissue. Here we can find blood vessels, nerves, different types of glands, and also the lymphatic tissue will be located here. Then we have the tracheal cartilages themselves, and then the adventitia, which is this elastic connective tissue overall. Now here we can actually see the bronchial tree, and so once again we can actually go deeper and deeper, into the lungs and the bronchia as we actually go further down. Now, the terminology that they're using here is a little different than what we used in lab. They're using the term main bronchi, lobar bronchi, segmental bronchi, and then smaller bronchi. We go with primary bronchi, secondary, and tertiary. Either of these names are correct, so feel free to interchange. And then we also will end up with these much smaller bronchi, and these are the ones that are identified by red here. And so they account for the majority. But the important thing to remember here, bronchi are not bronchioles. That is an important thing to keep in mind when we're talking about the anatomy. Now, bronchitis, and it's something that many people experience this, it is inflammation of the bronchi, and it can be caused by a number of things. It could be bacterial or viral infection. It could be due to inhaled irritants. Acute bronchitis, this actually occurs during or after an infection. Symptoms include coughing, sneezing. This is something that you'll see pain with inhalation, and that's a little different than a number of other respiratory disorders, and fever. Most acute cases of bronchitis will resolve in about 10 to 14 days. Chronic bronchitis, on the other hand, this typically is due to long-term irritant exposure. We're going to see lots of mucus, cough lasting for extended periods of times, up to 3 months. When we talk about chronic bronchitis, this also results in a permanent change in the bronchi. And these permanent changes increase the likelihood of future bacterial infections. Now here we see the bronchial tree, and the main bronchi, once again, they're supported by these incomplete rings of hyaline cartilage. It's going to keep them open. The wall support is also going to be cartilage, which will lessen as the bronchi divide. Now we get to bronchioles. Now keep in mind, bronchi and bronchioles are not the same. Bronchioles do not have any cartilage, but they do have smooth muscle. So we can see bronchoconstriction, which results in less air moving through the bronchial tree, also less entry of potentially harmful substances. Bronchodilation, this results in more air moving through the bronchial tree. Now, if we look at asthma, this is a condition which results in episodes of bronchoconstriction accompanied by wheezing, coughing, shortness of breath, and excess mucus production. there are asthmatics that have more sensitivity to airborne agents. We can also look at this as a localized immune reaction occurring in bronchi and bronchioles. And once again, the walls of the bronchi actually become permanently thickened. And the primary treatments typically for someone that has asthma will be inhaled steroids and bronchodilators. Now, there is a type of asthma that's known as exercise-induced asthma, and this actually leads to excessive constriction of airways. Now, it doesn't necessarily happen during exertion. Keep in mind we have beta-2 receptors that we can find in the smooth muscle of the bronchioles. So during sympathetic drive, these beta-2 receptors, when epinephrine, norepinephrine binds to them, will result in bronchodilation. Typically what happens is when someone is done exercising, that is when they'll actually get a reflexive bronchoconstriction and the asthma attack associated with that. Here we're starting to see the bronchioles as they terminate into the alveoli. And there are a couple of things that I want to point out here. Okay, we can now start to see the alveoli themselves. Remember, we're now talking about these areas where gas exchange is actually going to take place. We can actually see a couple of things here that I want to point out. Very well vascularized. Okay, that's going to be really important when we look at pulmonary gas exchange. But also we're going to see a lot of elastic tissue. And we're going to find out that this elastic tissue really plays an important role when we're talking about respiratory function and respiratory physiology.